How does this approach, the clinical reasoning approach, fit with the Pharmacy First initiative?
Well, I think hopefully it will help pharmacists establish the diagnosis with more confidence and more accuracy. Obviously, the Pharmacy First is a great addition to community pharmacy. It allows the pharmacist access to medicines which ordinarily would be prescription only and may mean a referral to a GP. So hopefully they'll be able to manage more conditions without having to refer and block up the GPs. The issue with Pharmacy First, though, you've still got to make that diagnosis. You've still got to get to the point that you are confident that you are dealing with condition X. And then you can use the Pharmacy First service to supply the appropriate medicine. So for me, the Pharmacy First is great in terms of management, but it's not necessarily accounting for the differential diagnosis. The pharmacist still has to do that. And this is where I think the book will help them.
From what you've said, clinical reasoning is going to be very important to the further development of pharmacy practice. So should clinical reasoning be taught at undergraduate level?
Well, I think clinical reasoning is creeping into undergraduate courses. It's not universally taught, I don't think, at the moment, but because of the changes to the undergraduate curriculum to embed independent prescribing, then clinical reasoning and decision making is starting to be more widely taught, because at postgraduate level, when you have an independent prescribing course, that's one of the things which the GPHC say must be taught. So it will be cascaded down into the undergraduate programs.
So far, so good. But won't all this be done by artificial intelligence in future?
I don't think so. AI obviously is going to play a larger role in how we teach the future pharmacy workforce. But clinical reasoning is fundamentally a thinking and cognitive process that you have to do yourself. So I think AI will be used to create test cases, give students opportunities to practice this clinical reasoning in a safe environment where they can build up their experience. So I think it will augment and supplement how we teach clinical reasoning, but the actual process of how you do clinical reasoning has still got to be thought through by the student themselves. So AI, I don't think will ever replace that.
And how do you envisage that clinical reasoning skills will support the further development of community pharmacy?
I think pharmacy have to embrace clinical reasoning for a couple of reasons. The first being that if we are going to move more and more to a clinical profession and be asked to do yet more things, and things like the Pharmacy First service is probably going to be extended, then the way in which pharmacists arrive at a differential diagnosis is going to be more scrutinized. And people like general practitioners who have been taught clinical reasoning as part of the way they make a diagnosis, I think will see that pharmacists are approaching that type of activity in the same way that they would. So it gives pharmacists a little bit more credibility, I think, because pharmacists will be taught the same way that GPs are. GPs will therefore maybe have more confidence in what we're doing because we're adopting the same approach.
To take this a little further, then, clinical reasoning is in some ways a new activity for community pharmacists. So they will not be experts for a little while yet. What are the challenges that you see here?
Yeah, you're absolutely right. Clinical reasoning, to be very good at it, takes practice. And if you look at the literature, it talks about being a novice, moving through to expert practice. And how do you go from novice, i.e. not really use clinical reasoning much, to expert? Well, the key thing really is experience. The more clinical cases you see of a similar presentation, the more you become familiar with how that presents and you start moving away from novice to expert. The biggest challenge for pharmacists is how do you get that feedback as to know you're doing a good job, okay? Because if I'm unsure of the diagnosis, safe practice is I refer onward to normally the doctor. Most times in community pharmacy, you don't get feedback from the patient or the doctor to tell you whether you were right or wrong. Now, for us to become good at clinical reasoning and more expert, that loop needs to be closed. And I think it's important that pharmacists try to talk to their GPs when they're making these referrals to say, well, I'm referring this case to you because I think it might be this, but I'm not sure. I'd really appreciate it if you could tell me what you think so that I can improve for next time. And by doing that, you are able to raise your ceiling of competence so that if you're there, but you get feedback on cases, over time, your ceiling of competence goes up and up and up, and you're able to treat more and more patients.
And my last question is, what is your vision for community pharmacy and its non-medical prescribing remit in 10 years' time?
Oh, crystal ball time.
Mm.
Well, I can only see the clinical role extending further and further. I think 10 years' time, most pharmacists will be independent prescribers. There may be a few still not being prescribers because they haven't actually upgraded. But I can't see community pharmacy doing much dispensing. I think they might dispense the odd acute prescription, but everything else will be done remotely and probably postal, which will allow the pharmacist to concentrate on service provision and also take over long-term condition management for people who are stable. So many of the roles that GPs currently perform, I think, will be performed in a pharmacy, and patients will be directed to the pharmacy more and more and more rather than the GP. So I only see the clinical side of pharmacy growing and the traditional kind of dispensing side of pharmacy disappearing. And I think we will, at that point in 10 years' time, be a very clinical, patient-facing profession. I think the digital side of pharmacy will increase, and that will hopefully allow greater communication between pharmacy and general practice services so they're better integrated.
Professor Paul Rutter, thank you very much for talking to us about your insights and experiences in this important field, and of course your new book. That has been enormously interesting, and we look forward to seeing how it develops. For more information about Paul Rutter's work, please visit our website using the links in the description, and please subscribe for more videos, news and journals. For updates straight to your inbox, please follow the links below. And thanks for watching.